My name's Mary Leamy. I'm a senior lecturer in mental health recovery, and I also do work on staff wellbeing. So I'm speaking about my work on mental health recovery, and I thought I'd talk also about recovery colleges. So some of you will know that we are keen to work with Chiang Mai University to um, develop our research collaboration. And one of the examples of doing this was to put in an application to set up a mental health recovery college in Chiang Mai. So I'll explain what that is. But first of all, I'd like to explain a little bit about the kind of work that I've been doing on mental health, personal recovery. Essentially, mental health recovery can mean different things. So the first thing is to understand what we mean when we talk about mental health recovery, because people have different understandings of what that is, and it's really important that we have a common understanding. So I'll talk about the differences between the way that people use the word recovery, so what it does mean and what it doesn't mean. And then I want to talk about how mental health practitioners can support recovery. So I'll give some examples of the kind of ways in which people can do that. And I'll give you some examples of some specific interventions and initiatives that have been developed around the world to support mental health recovery. And I will talk specifically about our Refocus intervention, which was a piece of work that was conducted in the UK to develop a program of work to support mental health professionals in community care, support personal recovery. So I'll tell you a little bit about how we did that. So first of all, what is mental health recovery? Well, the first thing I want to make sure you understand is the difference between what we call clinical recovery and personal recovery. So around the world, people talk about the recovery model and recovery, and they are actually talking about something different from clinical recovery. So clinical recovery is defined as in psychiatry, it's defined as full symptom remission, and that people are able to live full or part-time, they're able to do full or part-time work um, or education. So there's an element of being able to function independently, that they're able to live independently without supervision from anyone else. For example, from informal carers, from family and friends, and that they have friends that they're able to do activities with, and that is sustainable for 2 years. So quite a precise definition of what we mean by clinical recovery. Now, mental health services traditionally have been set up to deliver treatment and care around that definition of clinical recovery. So the challenge is to try to develop services which are focusing on not just on clinical recovery, but personal recovery. So personal recovery isn't trying to replace clinicians focusing on symptom reduction and other ways of supporting people with mental illness, but it's trying to expand the agenda, to expand what clinicians can do to support people that have mental health conditions. So personal recovery, when we started in the UK, we had got funding to do a large program of work for 5 years, and we needed to work out where we were going to start from. And this is a very widely cited definition. So any paper on personal recovery or people talking about the recovery model, they will probably be citing this definition because this is the one that it started from essentially. So you can see it's quite old. But personal recovery is defined as a deeply personal, unique process of changing one's attitudes, values, feelings, goals, roles, and skills. And it's a way of living a satisfying, hopeful, and contributing life with the limitations caused by illness. So that's the key thing, is that it's supporting people that may well be still experiencing mental health symptoms, but the role is to expand the remit or the agenda for the health professional, so that all of these things are important to help people have the most satisfying, rewarding life. So we have a local mental health trust called South London and Maudsley Mental Health Trust, who like to keep things very simple. They've got a very nice short definition of recovery. Their definition of recovery is recovery involves living as well as possible. So nice way to sum it up. But essentially, that's what you're trying to do is to enable people to have the best, most satisfying, rewarding life that they can personally have. So we have one word with two meanings. And one of the challenge is to make sure that everybody understands and they're talking about the same thing. So the clinical recovery, the kind of traditional definition of the word is, we would say it's focusing on what the professional priorities are, the professional's agenda. So they're very much talking about curing or removing or addressing symptoms, addressing people's deficits or needs. So it's very clear that that's what they're addressing. The definition of clinical recovery, as you see, is partially operationalized, and it's argued it's not highly aligned with patients' views. So there's work on what patients would like, and they've recognized that patients, what they would like from their clinicians is broader than just focusing on reducing their symptoms. So personal recovery, that has a long tradition. So the personal recovery didn't come from, it's based on a long tradition of mental health service users advocating for a service and a system which supports them to have a better standard of better quality of life. And what's important is it's focusing on what they say is important. It's their priorities for having a better life. So part of the intervention for anyone supporting service users to become more recovery orientated is to understand what they would like support with. So understanding what's personally meaningful for them, what purpose they would like. So that's where the intervention quite often focuses on, is actually understanding the person and how they feel that the clinician can support their recovery, which is individual. And as I said before, we started with that definition of recovery. From a research perspective, that's not enough to be able to design a program of work. So we needed to operationalize to be able to guide our research. So we needed to have a theoretical underpinning for what recovery means. That wasn't developed when we started, and that's one of the things that we needed to contribute was to be able to pull together all of the work that had already been done to come up with a theoretical understanding of what personal recovery is. So the key messages, just to kind of summarize this a little bit, is that personal recovery and clinical recovery, there was not too much of an association. So it's important to recognize that if you're evaluating or developing an intervention, you need to be clear what you're focusing on, and the fact that there is empirically, so that the way that we've tested it, we know that the association between clinical recovery and personal recovery is quite different. So personal recovery has been mental health policy around the world for about 25 years. In the UK, we had our first mental health national policy in 2001. Here's just some examples of countries that have policy to support mental health practice. The challenge is that although the ambition to become more recovery orientated has been national policy for a long time, the way in which we can support clinicians to become more recovery orientated, it hasn't been clear. So one of the reasons why we developed our research project was to be able to be very clear what clinicians can do to support recovery. So as an example of of a way of supporting recovery. It's not the only way, and I'll give you some other examples of how you can do that. But we wanted to be quite concrete about what you can do to support recovery. So it's not just something you talk about, but you actually have a clear idea of the different skills, knowledge, and tasks that you need to do to support recovery. So I'm going to tell you a little bit now about some part of this Refocus project. I said it was a 5-year program of work, and we had a number of sub-studies that led to a randomized control trial. So our study was to prepare the way to be able to run a randomized control trial. Previously, the research had been qualitative, and so there hadn't been a piece of work that had done a randomized control trial of a recovery intervention. So to be influential in the UK, certainly, certain styles of research are important. They're regarded as more influential. The randomized control trial is regarded as more influential. To persuade policymakers to fund changes in services, we needed to run a randomized control trial. Now, I've said that it wasn't clear how to have a theoretical foundation for developing an intervention. So we wanted to develop an intervention. So there wasn't an existing intervention to support recovery. We needed to develop it from scratch. But to begin with, we needed a theoretical explanation. So what we did is we did a piece of literature review to pull together all of the qualitative research that had been done to be able to have a firm foundation for selecting recovery measures, for developing and selecting aspects of an intervention, and to be able to be regarded as conducting robust research. So we needed to explain what the theoretical underpinning was. And just to give you an overview of what we did, we did a preliminary piece of work, which is developing a literature review conceptual framework. And then we wanted to test how looking at different populations, does it fit? What we developed, does it fit for different populations? So we did some extra work to look at whether or not it fits for minority groups, Black and ethnic minority groups. And we also did a piece of work to see whether or not something that had been developed would have cross-cultural validity. So there was, in addition to the initial literature review, there's some extra work to be able to show that it was relevant to different populations. And we also wanted to make sure that it was relevant for current service users. So because our intention was to do a randomized controlled trial of current service users, we had developed a theoretical explanation during our literature review, but we recognized that the literature was based quite often on people that had had a diagnosis of mental illness for quite some time. So we were wondering whether or not people's understanding of what personal recovery was would be similar to people currently using services, so newly diagnosed people. So we also did some qualitative work to see whether or not our conceptual framework was valid for people currently using services. So you can see how we were beginning to make the case for why this is a robust piece of work. So what I'm going to talk about now is the CHIME framework, which has been widely cited. So unusually for a piece of work, it's caught people's attention, and it's now widely cited around the world and widely used to help people talk about what recovery is, and also to develop interventions and to develop measures. So what we did for our own purposes has now been beneficial for other people. But I think it's partly because of the way we went about it, which is why I wanted to explain how we did it. So what we did is we did a literature review, and we looked at ways in which people had explained and developed some preliminary theories of what recovery is. So as I said, most of the literature was qualitative, and there were some examples of ways in which people had developed different types of model. So when we looked at the literature, we did a detailed analysis of all the papers. There was 97 papers, and we did a qualitative analysis for all of those 97 papers, and we came up with three different ways in which you can conceptualize recovery. The first one, we identified the ways people conceptualize the journey of recovery. So there were commonly different ways in which they explained it. So we call that the characteristics of recovery. So quite often people say it was a trial and error, that it was a long-term process, and they were kind of giving some common ways in which they describe recovery. So that was our first theme. Our second theme was recovery processes, which I'll explain in a minute. And our third theme was how people conceptualize the journey of recovery in terms of stage models. So for those that had developed a model of recovery and came up with stages, we also had a third theme, which was to look at any existing models of recovery. And we looked at, there's a model called the trans-theoretical framework of it's commonly used in psychology. So we mapped all of the existing models across this model to see whether or not there was any commonality. So how many phases, how many stages did people say? So it usually varied between 3 phases and 5. Very commonly, the first stage was about developing hope. So now I'm going to explain what this the second theme, which is the one that has got people's attention. So even though we had different themes, this is the one that people have found most useful because it describes the different recovery processes. So the chime stands for connectedness, hope and optimism, identity, meaning and purpose in life, and empowerment. So here it was based within the connectedness recovery process. Here you can see the sub-themes. These are the common sub-themes within this connectedness. So what we're saying is that it's important to support your recovery, you need to be connected to other people, essentially. I mean, it's not difficult. But the literature was saying peer support is absolutely essential. And the definition of peer support, within the time that we did this, it was largely about personal support workers. So people that have experience of lived experience of experiencing mental illness, but actually working to provide support for fellow people with either the same condition or related conditions. Being part of the community was really important. Having support from others and relationships. So all of those that they have a wider explanation, but that connectedness is really important. There are overlaps between these different recovery processes. So to be able to demonstrate what the recovery is, we needed to try to come up with a way of describing it. So some common themes, but in reality, there's some overlap. So most commonly, there's a overlap between connectedness and hope. So when we talk about how clinicians can support recovery, we talk about having hope-inspiring relationships. So that first step, in all of the stage models, that first step is about hope, having somebody that believes that recovery is possible. So I think if somebody, sometimes people ask me what my favorite recovery process is. I think it's a strange question, but the hope, actually having a clinician that believes in you. When some people are at their lowest, they don't believe that it's possible to recover, but having a clinician that recognizes that part of their role is throughout the process to support people's belief in recovery is absolutely essential. So the second theme about having hope and optimism is really important, but I think it's really underpinned by that they really believe that it's possible to recover. And one of the things that peer support workers can do is to demonstrate that they have been there. Maybe they've had the same diagnosis, they've had a similar life experience, and that they can show that it's possible to recover. So they become role models. The identity theme is really important in terms of helping people move beyond their understanding of what their lives are with the diagnosis of illness. So it's about growing beyond the diagnosis and helping people understand what they need to do to have a positive identity. The fourth theme is about meaning and purpose in life. This is probably the largest in terms of the evidence. This is probably the one that's got the most evidence in terms of what this theme covers. But essentially, it's about having how can people understand their experience? So the meaning of mental illness experience, but also what can they do to have a better quality of life. So there are many, many different aspects underneath these large themes, which explain what can be done to support people to have a better quality of life and grow beyond the diagnosis of mental illness. And then the last broad theme, this last process is about having empowerment. So within this theme, having control over your life is really important. In terms of translating that to services, it's around helping services work in a way where they're supporting people to have control and make decisions. So there are many, many research projects now, which is about developing shared understanding, shared responsibility for care. So it's not the clinician's responsibility, it's either the service user's responsibility or the patient's responsibility, or it's a shared responsibility. Just checking time. So this is the paper that we published in 2011, which if you're interested in the source of the work, this is the one to read. But now I want to move on to let's make it a little bit more practical. How can you support recovery? So there was no shortage of books and guidance about how you support recovery. So there are many different examples and guidance about how you support recovery. But it can be challenging to navigate all of this wealth of information. So one of the other pieces of work we did within the Refocus project was to try to gather all the evidence together about how do you support recovery into practice. And what we found is that there are different levels that you can support recovery into practice. So the first level is how do you support personally defined recovery? So what tasks, if you're working with an individual patient, what tasks could you do? What ways of working could you use to support your relationship with an individual patient? And what style of relationship? So not just what do you do, but the style of the relationship is really important. So in terms of developing our intervention, one of the ways in which we needed to work out what we were going to do for the intervention is to work out exactly where we were going to focus our energies. So we focused our intervention on the style of relationship and the way that the tasks that we ask people to do. We also recognise the organisational commitment. So in the UK, we have large mental health trusts, and for clinicians to work in a recovery-oriented way, it's not enough just for an individual to be motivated to support somebody. We need to have within parts of the service and within the organisation itself, very important that there's a clear leadership to say, this is what we'd like you to focus on and this is how we want you to do it. And then in terms of society, there's a whole theme about how do you support citizenship. So strategically, we were working about where you focus the intervention. And because we were wanting to do a randomized control trial, we focused it on the level of the team. So we were developing an intervention that could be used by individual clinicians working with their service users, but also as a way to support a team. So those two different levels at which we were trying to change. So we were trying to change the individual practice and how the mental health team work. So I said a little bit about the fact that there are different other examples of how you do recovery or into practice. I won't go into too much detail. I'm going to focus on recovery colleges as one example, but there was a very useful paper published just over 10 years ago now, which looked at the most common ways in which people have developed to support recovery or into practice. The peer support worker is one of the common ways around the world that people have developed a way of changing services, to have people that have lived experience of mental illness being paid to support and work with clinicians, to role model recovery and to work in a different way to support recovery. But there's some other examples here. And as I said, I'll just talk about the refocused intervention and the recovery colleges. So we were looking at, as I said, we wanted to influence policy, and we know that a randomized control trial and a systematic review of the evidence are really important to persuade policymakers. I might skip over this a little bit because I want to talk about the intervention. But essentially, I said we were doing lots of different aspects of the project. One of the ways in which we needed to prepare for the randomized control trial was to develop a new measure of personal support given by a clinician to a service user. So we did lots of literature reviews to identify how to measure recovery, recognise that there wasn't one suitable for our purposes, so we developed our own. This INSPIRE measure is based on the CHIME framework. So there's now a family of measures that support research and clinicians to support recovery onto practice. So the initial measure was 20 items, but there's been different shorter versions that can be suitable for clinicians working in clinical practice. So there's a brief INSPIRE measure of recovery support, and there's also an outcome measure called INSPIRE O, so much shorter. Now, the refocused intervention, essentially we had some priorities for how we develop an intervention. So it wasn't an intervention that was targeted at a particular condition within mental health. So we call it a transdiagnostic intervention. So our participants were people that were receiving care from a community mental health trust. So they had different conditions. We wanted to prioritize the importance of lived experience, consistent with the recovery approach. Very important for us to develop a project and prioritize the experience of patients and listen to their views and how we design the research, but also to come up with an intervention that would prioritize the experience of service users. And as I said before, we wanted to particularly focus on minority groups. So traditionally in research, some groups are harder to reach. We particularly wanted to focus on people with Black and ethnic minority backgrounds to make sure that the way that we design all of the aspects of the research focused and included these groups. I'm going to skip over these. I will share the slides so you can see them, but there's some things I want to focus on a little bit more. So we were guided, but we had some key values that we used to guide how we went about this. So I've said we had building blocks. So I'm hoping you're following what I'm saying. So essentially, we wanted to define what recovery is, and then we also wanted to come up with an intervention that we could help clinicians to use to support recovery. And we needed, because it was a trial, we needed to make sure that we had robust ways of measuring recovery. So there were a number of different steps that we had to do to get to the point where we could do a randomized control trial. So these are the references, if anybody would like to look at the references just to support what I was saying about the theoretical framework for recovery. So the original paper and then the cultural validation, where we compared different countries to see whether or not there was consistency across different countries in the way that they understood recovery. And then I said we did some work to validate it with current service users. So the intervention is just on these two areas: working relationships and supporting recovery-oriented practice. I might move over. Sorry. These are all the papers that, if you're interested, you can look at. So the CHIME framework, as I said, I think we've done lots of studies where we've seen whether the existing measures are aligned to the theoretical understanding of recovery, so the CHIME framework. So there are many different reviews that we've done to see whether or not they're valid. Are they measuring what they should be measuring? So this is just as I said, this is the measure that we developed specifically for the trial, but has now been used around the world and been translated into many different languages. And there is a Thai version of the short version of Inspire. And there's now a new short global Inspire, which again has been translated into Thai. So we know that there is work being undertaken in Bangkok at the moment to validate the Inspire for use in research studies in Thailand. So it's a slow process, but we're trying to make sure that it's appropriate to use in different settings. So I'll now talk about the refocus intervention. So it was an intervention to support clinicians to help their patients become more recovery orientated, and it involves two strands. So it involves tasks, which we've called working practices, and it also includes an element of skill, which is where we taught clinicians to have a different style of relationship with their service users. So we taught them how to use coaching skills. So we work with trained coaches to develop a manual to support the intervention, so that we were teaching psychiatrists, nurses, occupational therapists and social workers how to use coaching as part of the intervention. So we wanted them to be aware of the way that they ask questions and the style of working, and the working relationship is very key. So it's not just asking about what do you do, it's the way you do it. So it's very important for us to have, for them to be aware of the two aspects, specific tasks and the style of working. So to try to explain how an intervention works, when you get funding, you're asked to try to say in advance how your intervention will work and how you will measure it. So our intervention was split into two. So we were working to come up with some training to help people develop their style of relationship. So the training was around developing coaching skills, but we also, because it was a team level intervention, we also got the whole of the mental health team together to have conversations about how they understand recovery and how they're going to overcome some of the barriers, to the practical barriers of implementing recovery. So it's not enough just to come up with intervention. You need to try to work with people to find a way of making this work in practice, rather than just saying we'd like you to do this. We wanted the whole team together to work through how they would implement this. So we provided them with some support from mental health charities called Rethink, which is the national charity in the UK. And we also built in some time to support the leaders of the team. So different elements in which we were intervening. We were supporting the leadership. We were trying to support the way that the team worked together, as well as asking them to do some tasks. So the working practices are the tasks. We asked them to do three things. We wanted them to change the way that they assess. So rather than just focusing on traditional styles of assessment, we wanted them to do a specific assessment around the person's strengths. So we did a whole literature review to identify what checklist we'd use. So we knew that it was the most robust way of doing this. So we asked, that was the first working practices, to ask them to do that. We also wanted them to have different conversations with service users to begin to understand what was important to them. So what are their priorities and their treatment preferences? And how can you base the identifying of their personally meaningful goals in an understanding of what's important to the person? So these elements are fit together to try to work out what person's strengths are and what their resources are, what is important to them, and what their personally meaningful goals are. So the personally meaningful goals will vary for individuals. It's an unusual way of doing a piece of research because it's quite individual. We know that what's important to one person will not necessarily be important to another. So part of the intervention was to identify and intervene at an individual level to identify what's important to particular service users. And then to explain how it was working, what we were trying to do was we were trying to break down the stigma that mental health workers sometimes have towards their patients. And sometimes we know that people might not believe that recovery is possible for everybody in their care. And so we were wanting to work to change that. We also wanted to make sure that they had a very strong understanding of what recovery is and that we were working to change their recovery attitudes. We wanted to give them particular skills. And in this case, it was skills in coaching and in delivering these different working practices. And then we were wanting to make sure that we could build on their intention. So to change behavior, we needed to think about how do you work not just in telling people this is the approach, teaching them how to do it, but actually intervening to encourage them to put it into practice. So we did some work to build on people's intention and motivation to put this into practice, and then we wanted to measure whether or not they'd actually put it into practice. So the last boxes, the yellow and the purple boxes, are about how we measured it. So we knew that we were trying to encourage people to be aware of and use their strengths. We wanted to help them identify personally meaningful goals. And we also wanted to support their recovery. So we had a number of ways in which we were trying to show that the intervention had worked. I'm going to skip over, I'm just looking at using a lot of time, so I'm going to skip over this. This explains a little bit more detail about what aspects we did to support each of these. So the how, the recovery promoting relationships, and the working practices, which I've kind of explained anyway. So in terms of what we found, we were working, it's a real world research. So we had 27 mental health teams that were working in two sites, and we divided them into those that received the intervention and those that didn't. The real world is that sometimes things happen that you have no control over as a researcher. And what happened for us is that some mental health teams were disbanded, and very tricky from a research point of view when teams are being disbanded. So they had no chance to implement the intervention. And also some teams were not able to implement for other reasons. They weren't able to implement it. So we could prove the hypothesis that this way works would encourage recovery into practice. But when you exclude the teams that were disbanded, it did work, which is fair enough. So this is our paper that reported on the findings, and we found that for those teams that did implement it, it was cost effective. It was reducing the number of times people went into hospital, and it was supporting recovery of those patients that received the intervention. So we evaluated both the outcome measures and also what people thought about it. So we did a process evaluation to ask what service users found helpful, and they really welcomed the discussions about their values and their treatment preferences and their strengths and the support to work on what they said was important to their personally meaningful goals. And interestingly, even though we couldn't find support for our hypothesis, it's been replicated in Australia and in France recently. So in Australia, they've taken the intervention and they've implemented it in their community mental health teams, but they've also implemented it in primary care. And for both of them, using a slightly different style of research, so using a cluster randomized control trial. So this is a style, it's a cluster randomized. So the area of interest is the team, but in this style of research, everybody receives the intervention. So it's easier for a research point of view to sell the intervention because everybody will get it. It's just we stagger when they receive it. So in Australia, they've found evidence using this piece of work. They've supported the primary hypothesis. How much time have I got left? Okay, I'm gonna thank you. I'm gonna quickly introduce recovery colleges because I think it's a really nice example of an intervention which has caught people's imagination. There are 220 recovery colleges all around the world. So it's an intervention that was developed initially in America, and then in the UK it was adapted and has particularly caught people's imagination in the UK. And now It's spread around the world. So all continents around the world have got recovery colleges, and it's an example of taking an approach and using the approach to support mental health clinicians to become more recovery orientated. So, recovery college, usually in the UK, it's located in a mental health trust, but it's separate. So it's taking an intervention and locate it in the field of education rather than in healthcare. So it's set up as an educational college, and the intention it's informed by recovery thinking. So it's all about helping people develop their understandings of what mental illness is, how to support and have a meaningful life, and to build this contributing, satisfying life. So recovery colleges are they have many, many different styles of courses, and most importantly, they have a different way of designing the intervention, the education, and delivering it. So here's some examples of recovery colleges from their perspective. So everybody, just as any university would, you set out what your courses are. So these recovery colleges have developed a program of courses that they offer service users who can self-refer. So it is a different style. Current service users and discharged service users can use a recovery college. So within a recovery college, the most important thing is it's set up to support recovery. So all of the courses are aligned to the CHIME framework. So the courses are aiming to help people improve in terms of their connectedness, their identity, meaning, purpose in life, empowerment and hope. And it's within the philosophy of adult education. And most importantly, in recovery colleges, we use co-production. So co-production is where somebody with lived experience of mental illness works alongside a health professional. So they work towards developing the course and delivering the course. And that's what makes it a recovery college, which is different from any other type of support for service users, is that they have this co-production. And I can get to skip over this because I'm a little bit tight for time. Um, so just before I explain this slide, so the students in the recovery college are unusual, and the students are somebody with experience of mental illness. They're also mental health staff, and they can be carers, so family and friends. So about 10% of the students in a recovery college are carers and family and friends. About the same proportion are staff, and the remainder are mental health service users. So it's the students that are unusual, and having mental health staff learn alongside students is really powerful. And the courses, all of the courses are delivered by one health professional and one service user. So they're all co-delivered, and the service user is able to share their experience and model recovery. And the courses can be many different types of courses, and the people can be quite inventive about what kind of course, but as long as it meets the CHIME framework processes, it will support recovery. So these are it's a large piece of research that's been done to evaluate what recovery colleges and how they work. And what they say is really important to make sure it works is that there's an empowering environment. So there's an element of safety and respect and supporting people's choices. That this style of having the way that they deliver the courses, the way they develop the courses, and the audience, you're changing the way that people usually work together, so that you're creating different styles of relationship. It's very good at facilitating personal growth, and it's helpful in shifting the balance. So we talk about using co-production to break down those traditional power dimensions. So this is I'm gonna end with this slide. So this is how we know that mental health recovery colleges lead to desired outcomes. So the research that's been done so far has showed that there are outcomes in relation to personal, interpersonal, and social levels. So most importantly, there are improvements in health and well-being, but it's also very helpful to build people's self-esteem, their confidence, and their sense of identity. It enables, because of the way that it's working, it enables people to have a better sense of empowerment and control and personal responsibility, and that it's also working on those connectedness recovery processes around their interpersonal skills, developing pro-social behaviours, and increasing and helping them support those personally meaningful goals that I talked about, and helping them think about what their future, talking about what they would like for that from their future, which is really important. So I'm going to end there, and I'm very happy to answer questions. Can you hear me? Oh, good. It works. So I think it's probably not helpful to think about it in those terms, to separate them. Do you remember I said that there's a lot of overlap? It doesn't really make sense to separate. You wouldn't try to implement recovery onto practice taking one, because we know that they're all important. So the way to break it down into those different 5 recovery processes is to help people understand what recovery is. So understanding that they're all related, and that you could develop an intervention which is primarily focused on hope. It hasn't been done because I don't think it makes sense. But there are some interventions that might be more about connecting people with community, for example. So the primary purpose might be to focus on one of those different dimensions, those different recovery processes. But from my perspective, it doesn't make sense, because you want to have an intervention that you can show uses all of those. They're all important. So, but being aware of what is important to support recovery has been very helpful to help clinicians and service users understanding what recovery is. So, for example, in the UK, one of the ways in which we know that they use the CHIME model is to support people when they're on a waiting list. So they've set up these CHIME cafes where they support people before they get access to mental health services, because in the UK there's a long waiting list. They offer something to people that are on the waiting list. So these CHIME recovery colleges, CHIME recovery cafes are opportunities for people to begin to talk to people about what recovery is, to begin to talk about what they would like from services. And by helping people understand what recovery is, it has shown that it enables the conversations when they do get to see mental health professionals. It enables those conversations because the people that are on the waiting list have already begun to think about what they might need to support their recovery. So helping people have those conversations is one of the ways we know we've had impact, is because we know there are many examples of people using this to be able to talk about how. I know people talk, for example, and they ask service users, what would support your recovery in relation to developing your relationships? What kind of support would you need in terms of perhaps some ambitions, what would give you meaning and purpose in life? So thinking along those lines helps people be clearer what they would like support with when they come to talk to their clinicians. So there's many different ways in which this has been used in practice, but I think I'm really encouraged that it's been useful for helping service users understanding what recovery is. Does that answer your question in any way? Really challenging question. I think in terms of the way she's in the hospital at the moment, she sounds like she'd be an ideal role model for current patients. So I don't know whether you use her as a role model, but she sounds ideal as a role model for current patients. Within the UK, it's really fantastic to have people that can show that it's possible to move towards their recovery. We don't often talk about people being recovered. We regard it as recovering a life, and that there's not necessarily an end point. But it's part of a process. But in terms of how she's working, and the fact that she's currently in hospital, that will be one suggestion. I think in terms of changing societal attitudes, that's a real challenge. That's a real challenge. There are many different ways in which you can combat stigma, but it's not easy. It's not easy. One of the ways that we know this recovery college is very helpful is that it challenging people's perspectives of what is possible to achieve, even when there's a diagnosis of mental illness. So having those role models around the world to show and challenge people's views is so important at all different levels, because people have expectations of what is possible, the kind of life that's possible to lead with a diagnosis of mental illness, and all of those need to be challenged. But it's not a quick process. But I think having constantly finding ways in which you can break down people's attitudes, and like I was saying about the stigma in mental health workers, we also need to do that for communities. So the Recovery College is one of the ways in which you can do this, because you're bringing in the community to see what's possible. To see people that have a diagnosis of mental illness delivering courses can be really challenging. It really changes their views about what's possible. And I think we just need more role models. I think that essentially that's what I think, that we need to have more ways in which people can see for themselves the change in people, and the fact that they're able to achieve far more than they believed is possible. But it's a challenge. Okay, another really challenging question. Thank you. I think what I'd like to say is that I feel that we're moving, it's a transition. So the ways of understanding mental health recovery, you've seen what I've said, that the way that we can understand mental health recovery, those processes are not unique to mental health patients. And there are studies which have looked at the theories around personal recovery, and also more general theories about well-being for the general population. I think there will become a time where we don't talk about this. We just talk about well-being for the general population, which I think, I'm hoping we will get there. There is an awful lot of overlap already, but I think it's a process. So what I've said today, we know that a lot of those processes are very helpful in terms of if you were developing an intervention to support nurses, or they're very applicable. So I would encourage you to think more broadly about those processes which we know supports everyone. I'm not sure that's really answering your question, but that I think as I say, we're at this process where I don't know how long, but I think we will get there when we don't talk about recovery. We talk about what do you need to do to support anybody's quality of life. So the answer is we use many, many different types of measure. Let me just show this model that I showed you. This in terms of developing the trial, recovery is so complicated. We needed to use many different types of measure. So the hypothesis was based on a measure from service users using a tool called the Questionnaire of Processes of Recovery. And it was selected to measure the progress of recovery from the perspective of the service user. And it was a measure that was developed in the UK for a population of people with schizophrenia. So we chose that measure because it was the best measure for our primary outcome, which was that we were expecting service users to improve on their ratings of recovery. The Inspire measure that I briefly showed you, that's based on the CHIME, this is a measure that the service user completes about the contribution of the worker, the clinician, towards their recovery. So we wanted to see whether or not having an intervention like this meant that they would rate their worker higher in terms of the amount of support a clinician helps with the service user to develop their personally meaningful goals, to give them a better sense of hope. So all of those measures, those dimensions were part of the measure, the Inspire measure. So I will share these slides so you can see all the references if you'd like to look. So we were looking at that from the clinician's point of view. We asked them to rate their perspective of need. So there were the many different measures completed by the service user about their quality of life, their hope, their rating about personal recovery, but also from the clinician's perspective, did they think that the person was functioning at a higher level? And did they think that they had less need? So there were lots of different measures. It was to try to capture all of the different, because it's a very complicated intervention, and we wanted to capture lots of different aspects. So we used a range of measures, but the primary outcome was the questionnaire of processes of recovery. Okay, I'm really tired, so I've forgotten your first question, but I'll start with your second. In terms of supporting mental health recovery for those communities, you could use the CHIME model, but I think I've been working on a technique called psychological first aid. I don't know if you've heard of it, but it's an intervention that's specifically designed for lay workers to support people that have experienced natural disasters and public health emergencies. And I have a PhD student who's just graduated who is taking the approach that was developed to support people in China. So it's an intervention which needs to be culturally adapted. But what she did to culturally adapt the technique was to speak to emergency workers across China to identify what's important and how you develop stories which are culturally appropriate. So scenarios as part of the training. So she trained emergency workers that are based in a leading hospital in China they would be the ones that would be called out for an emergency. And so she trained them in how you understand mental illness and how do you support in those. It is called psychological first aid. So it's intended to be a rapid intervention, but it's a way of understanding what's important in those early stages of a disaster. But what she's now doing is developing it for emergency workers to apply to routine care. So it was an intervention which was designed for these disaster situations, but what she's recognizing is that it's important to train workers to understand their own mental health, but also to apply it to routine care situations. So that was your second question. What was your first? Yeah. So the Chime Cafe is not something I've had anything to do with, but part of the work that we have to do as academics is to work out how our work has had a real world impact. And so part of this was me discovering that mental health trusts have been setting up these cafes, and all it is an opportunity to be able to deliver something to people on a waiting list. So they bring people together. And it is run like a cafe, but they have usually it's a psychologist that comes in and facilitates conversations. So they have activities that are related to the CHIME framework, but it's having facilitated conversations in a group to help people think through what they would like from their services to support their recovery. So that's probably as much as I know. Um, um, I have never been to one. I'd love to go. But it sounds like an interesting way of supporting people before they receive formal treatment.